we're going to have an extremely interesting talk given by two members of our community, Donald Klein and Maurice Prater, who are known to a number of us in the Neuro-Psychoanalytic world here in New York and beyond. And they're going to be speaking on panic, separation anxiety, and endogenous opioids. So I'm just going to introduce the speakers and we'll get started. So Dr. Prater does research on anxiety disorders at the New York State Psychiatric Institute. He's also in private practice in neurology and psychiatry. And he's on the faculty of clinical psychiatry at Columbia University. And he's also a recipient of fellowships from both the American Psychoanalytic Association and the New York Psychoanalytic Institute. Dr. Klein is a faculty at the Department of Psychiatry of Columbia. He's also a professor of psychiatry at Presbyterian Hospital, and he's the director of psychiatric research and of the Department of Therapeutics at the New York State Psychiatric Institute. And he's had a very long career with a number of interesting positions. He's been the head of a number of medical and research units. He's been the past president of several societies, including the American College of Neuropsychopharmacology, the Psychiatric Research Society, and the American Society of Clinical Psychopharmacology. And he's been a consultant for the FDA and the NIMH, and a number of other positions I can tell you about. So I'm sure we're going to have an extremely interesting talk today from Dr. Prater and Dr. Klein. So let's get started. Thank you.
Which one of them are you using? I don't know. It's a great honor to speak at the Neuro-Psychoanalytic Institute, and I would like to thank the Pfeffer Center for inviting us. We regret that Mark Soames could not be here today, and are at the same time delighted that Max Allen was available at such short notice to chair this session, and thanks for the kind introduction. After my introduction, Dr. Klein and I will each take about 20 minutes to present you with relevant findings and work currently being done in panic disorder at the Psychiatric Institute. Time permitting, and if there is interest, I will finish with an outlook on a common condition that in several aspects resembles panic disorder, and it's migraine headache. The subject of today's mini symposium is anxiety, specifically panic and separation anxiety. The concept of anxiety is of central significance to psychoanalysis and to psychiatry, but it is perhaps just as relevant to general medicine and to the social sciences. Today, as in Freud's time, anxious individuals may seek relief from psychoanalysis. But more often, they will present to a general medical practitioner with what may be primarily physical distress. In the US, nearly half of panic patients are initially seen in a medical emergency room and may undergo extensive diagnostic procedures such as coronary angiograms for chest pain, or MRI scans of the brain for headaches or lightheadedness. Cardiovascular symptoms, particularly pseudoangina, false chest pain resembling a heart attack, are the most common symptoms in these panic patients' experience. Finally, to alleviate anxiety, whether consciously experienced as such or solely expressed as physical symptom, panic sufferers may self-medicate, usually with alcohol, benzodiazepines, or prescription narcotics, with all the personal and societal consequences that follow. To do justice to the scope of the subject is impossible in the time available to us. So what we're proposing for the next hour or so is a focused approach to specific phenomenological and biological features of panic disorder. Is there an echo in the back, or can you hear me okay? All right. The colorful phenomenology of panic has not changed since it was described by Freud during the infancy years of psychoanalysis 110 years ago under the term anxiety neurosis. Allow me to quote a few lines from the Katarina case, case 4 of the studies on hysteria, that is still among the best clinical descriptions of panic disorder and its consequence, agoraphobia. Besides, the text gives us a flavor of how and where psychoanalysis originated. If we take into account the overwhelmingly painful reality of traumatic separation and loss suffered by the vast majority of psychoanalysts during the first half of the 20th century, starting this week, 73 years ago, we may be able to better understand why psychoanalytic theory development paid attention only to some aspects of the anxiety experience, while sometimes turning a blind eye to others. But however related, that's another topic. As you may remember, Freud sets the stage by telling us that he's on summer vacation hiking in the Alps and trying to get away from medicine and, quote, especially the neuroses, unquote. He claims that because he identifies himself in the visitor's book as a medical doctor, he is promptly consulted by the sulky-looking innkeeper's daughter for her bad nerves. And I quote, "Well, what is it you suffer from?" "I get so out of breath." "Not always, but sometimes it catches me so that I think I shall suffocate." And Freud continues, and I quote, "This did not, at first sight, sound like a nervous symptom, but soon it occurred to me that probably it was only a description that stood for an anxiety attack. She was choosing shortness of breath out of the complex of sensations arising from anxiety and laying undue stress on that single factor." End of quote. As good students of Darwin and of affective neuroscience, we would take issue with this very Cartesian view of symptom choice, as will soon become clear. And Freud continues to question the girl, and I quote, "What is it like when you get out of breath? It comes over me all at once. First of all, it's like something pressing on my eyes. My head gets so heavy, there's a dreadful buzzing, and I feel so giddy that I almost fall over. Then there's something crushing my chest so that I can't get my breath. And you don't notice anything in your throat. My throat's squeezed together as though I were going to choke. Does anything else happen in your head? Yes, there is a hammering, enough to burst it. And don't you feel at all frightened while this is going on? I always think I'm going to die. I'm brave as a rule and go about everywhere by myself. But on the day when that happens, I don't dare to go anywhere." End of quote. Here's Freud's concise tabulation of panic symptoms. Anxiety attacks accompanied by disturbances of the heart action, such as palpitation, either with transitory arrhythmia or with tachycardia of longer duration, which is not always easily differentiated from organic heart affection, and again, pseudoangina pectoris, diagnostically a delicate subject. Anxiety attacks accompanied by disturbances of respiration, several forms of nervous dyspnea, attacks resembling asthma, and the like. I would emphasize that even these attacks are not always accompanied by recognizable anxiety. Of note, Osler had called asthma a neurotic disorder. There is also a very interesting paper by Karim Mansour with the title "Asthma and the Fear of Death" that was published in 1960 in the Psychoanalytic Quarterly, and that provides a vivid clinical description of the close connection between childhood respiratory disease, separation anxiety in both mother and child, and subsequent clinical panic in adulthood. Dr. Klein will tell us more about lung disease and panic in a moment. Waking up at night in a fright, which is usually combined with anxiety. Dyspnea, sweating, and so on is very often nothing else than a variant of the anxiety attack. Of note, Charcot's assistant, Charles Ferré, who Freud knew during his stay in Paris in the mid-1880s, had described somewhat earlier nocturnal panic attacks as paroxysms of suffocation anxiety that are not triggered by cognition or bad dreams. Again, we will hear about nocturnal panics in a while from Dr. Klein. Now, over the intervening century, Freud's list of panic symptoms has grown by a few relevant observations. So let's modernize that list. What are the features of panic that a good working hypothesis should attempt to explain? Experience of air hunger, smothering sensation. This we already know from Freud. Air hunger is the key feature of panic. One of the oldest observations and more common in female than male panic patients. In fact, Charcot had noticed the respiratory abnormalities in panic anxiety and studied them with a rather modern-looking graphic respiratory tracing device. That's how that looks like. In panic patients, panic attacks can be specifically triggered by lactate infusion or CO2 inhalation, which requires an explanation, but also uniquely allows us to study panic in the laboratory. Panic attacks are blocked by imipramine. Imipramine, however, does not alleviate anticipatory fear. Panic disorder does not worsen and perhaps improves under external threat and worsens with relaxation. That panic sufferers, if anything, function better under death threat was first noticed in London during the Blitz, and then again in Israel during the first Gulf War missile attacks. This observation plainly contradicts a cognitive model of extreme fear that supposedly catastrophically culminates in panic. I have also found that certain highly anxious but very introspective patients may become even more distressed when they notice that their panic attacks are getting worse with rest, such as in the evenings or on weekends. After all, they have been told all their lives that they should just relax in order to feel better soon. Epidemiology. There is, in the anamnesis of many patients with panic disorder, true catastrophic loss or separation. I suspect my observational data about this, and I would be interested in sharing vignettes during the discussion. More formally, life events were assessed during the year before panic onset. Compared with controls, panic patients had more numerous and severe independent life events, defined as beyond the subject's control, particularly losses in the month before panic onset. Loss events had the strongest relationship. Other studies found significant associations between maternal death and parental separation or divorce with adult panic disorder. It goes without saying that the individual context of the loss experienced will contribute in some way to symptom formation. An integrated explanation of panic onset in any given case will have to take into consideration at a minimum the contribution of epigenetic and transgenerational vulnerabilities to separation, the role of increased vulnerability through cumulative traumatic loss. In other words, there's a doses effect. Also of note, the loss event preceding panic onset is not limited to the loss of a loved person, but for instance may occur in the context of exile and migration. In other words, loss of culture, of language, of socioeconomic status, and so on. There are, of course, intrapsychic factors that are uniquely human, that need to be taken into account. The symbolic meaning attached to the loss, as in the aging New York attorney who is losing his corner office at the firm, and the level of ambivalence prior to the loss experience. On occasion, anniversary reactions can manifest themselves as new onset panic attacks or worsening of the condition. Separation anxiety and school phobia. Dr. Klein first noticed high levels of separation anxiety in the childhood history of panic patients. This was confirmed in a long-term prospective follow-up from childhood to adulthood over almost 20 years. Separation anxiety in childhood increases the risk of developing panic disorder when these children grow up. To close the epigenetic circle, panic disorder in parents increases the risk of separation anxiety in their children. Finally, yet another oddity, as well as a tough nut to crack for cognitive theorists. Many panics are distressing, even painful, but not necessarily fearful. Reitman and Fleet showed that a large proportion of not primarily anxious patients with what Freud had called pseudo-angina, that is chest pain or physical exertion despite normal coronary arteries, have panic disorder. Their chest pain could be reproduced with the CO2 inhalation challenge for panic. The relatives of these patients often had anxious panic disorder. Speaking of physical symptoms that have no apparent organic explanation, what about conversion disorder itself? Like Charcot a century before him, Russell studied patients who presented with unexplainable neurological symptoms, resulting in negative neurological workings, but who were not primarily anxious. Their symptoms, usually dizziness or non-neurological weakness or numbness, could be reproduced with the lactate infusion challenge for panic. This was blocked with anti-panic medication. This overlap between anxiety, unexplained pain, and other physical symptoms, and alexithymia, is the true gray zone between psychiatry, neurology, and general medicine, and should be a pioneer research area for both the medically informed psychoanalyst and the psychoanalytically informed neuropsychologist. But now we have the great privilege of hearing more about the history of biological anxiety research from one of the early innovators in the field. Don?
I'd like to go ahead and talk about this from a slightly different perspective. And the general thrust of what I want to say is twofold. One is that the words that we use in describing patients are words that come out of general English language, and they're much too broad. They don't cover the details. The whole experience in psychological, psychiatric, and biological studies has been moving toward a much more modular view of how the brain acts and how our emotional system works. We have many things that are essential to our well-being: air, water, food, and we have many threats that one has to deal with in evolution and individual life: predation, infection, parasitism, social conflict, and as Bowlby pointed out very brilliantly, separation in infancy, and nothing that has to be learned, is a built-in problem. And each threat is distinct. There's no all-purpose scientific difficulty. We've had many systems developed that something is going wrong and that we're going to be taken care of. And there's no all-purpose response. There are a variety of ways to deal with a variety of threats or of unsatisfied needs. So the adaptive sequence usually is a specific activation of a distinct detector by a threat, for instance, dehydration, caloric deprivation. If that gets severe, we then have conscious feelings, in this particular case, thirst and hunger. That's an alarm system. We don't usually think of an alarm system because alarms are thought of as going to bang because of something quick precipitating them. But thirst and hunger build up over time. One of the ways that you can tell that you're dealing with an alarm system is if the deprivation gets very severe, it's all you can think about. If you're thirsty enough, you just think about water, how you're going to get it. If you're hungry enough, etc., etc. So that these are alarm systems. Predation and air deprivation are two alarm systems that require quick response and therefore cause quick onset of distress. The other one that is very quick is infant separation, which results in a specific response, which is crying, an appeal for help. The mother walks out of the room, kid starts to scream. Now, pathological reactions. You understand that this is a complex process, so that you start with perception of a situation, anticipation of possible danger, the feelings that one has, the alarm that go off, the thoughts about it, the plans you're going to have, the preparative actions you take. This is a complex process, hierarchical, and goes in a variety of ways. And something can go wrong at any level. And if something goes wrong at any level, then you have a maladaptive situation. The obvious way to know is that something's going wrong. I wanted to say how I got involved with panic disorder. I was working at Hillside Hospital, which was a long-term psychoanalytic hospital. This is 1961. It was a hospital, the average length of stay was 10 months. It was mainly back in the Jurassic Age. And the patients received 3 times a week psychoanalytic psychotherapy. And when this failed, they were referred for medication study. We were interested in imipramine, this antidepressant, which was not yet on the market. We noted that a number of patients who had depression also had their anxiety calmed when they were on imipramine. We had patients there who were predominantly, it would seem, anxious. They were often called schizophrenic, but everyone was called schizophrenic. And they did not work in psychotherapy. After some months, they got referred. And we suggested they try this experimental imipramine, which they did, saying that anything was better than being sent home. And I'll just tell you about one anecdotal patient. One of the first patients, we put him on imipramine to talk with his therapist, the therapist supervisor, the nursing staff about how he was doing, and saw him on a weekly basis. And we knew by then that imipramine took a while to work. And finally, after 3-4 weeks, during which time he complained incessantly, and during which time the therapist said nothing was happening, the supervisor said nothing was happening. Finally, the 3rd or 4th week, one of the nurses says he's better. And we said, how do you know he's better? And after a discussion, they said, well, he's been running to the nursing station every day for the past 10 months saying he's dying. And we hold his hand, say, you're not dying, your heart's okay, it's just this terrible anxiety of yours. And he, after a few minutes, 20 minutes or so, he'd wander away, and then 3 or 4 hours, he'd be back. And then he hasn't done that for the past week. So in back, the patient said, I understand you're feeling better. And the patient said, how do you know? And I said, well, the nurses told me. And he said, how do they know? And I feel terrible. I feel just as bad as I ever did. So I finally said, it did true. You've been running to the nursing station for almost a year now. He said, yeah, and you haven't done it for the past week. The patient was actually surprised. He was stunned. He said, I guess that's true. I said, why not? He says, well, I guess I've learned they can't do anything for me. almost a year, this week, they can't do anything for you. And he said, well, you know, tell them sometime. Anyway, man is an essential behaviorist and a populist. Now, it took a while to figure this thing out, but mind you, this fellow was not running the nursing station, but he still was demanding accompaniment to go around the grounds. He still said he wasn't going to go anywhere alone, by himself. It took a while to figure this out, and going over the history of these people, and this has been repeatedly shown in many clinical studies, and Freud noted that in 1895, the onset is a panic attack, a panic out of the blue. The person has a terrible experience. As Maurice has told you, many of these people don't seem that fearful necessarily, but many do. A lot depends upon where you're studying the patients. If you're studying them as I was doing in a long-term psychiatric hospital, those patients were terribly anxious, terribly fearful, terribly concerned they might die. If you're studying these patients in a cardiologist's office, they're talking about their chest pain, their difficulty in breathing, and they're not telling you about terrible anxiety and terrible fearfulness. So settings matters tremendously. So anyway, you have this, what's here a vertical stroke to the attack, which leads to help appeal behavior. You run, say, I need help, please help me, turn to somebody, etc. Then you eventually get to the emergency room, nothing much happens there. Then you get another one, and then another one, and then in between attacks, one begins to have a chronic anxiety and a chronic anticipation about the attack. When is the next attack going to hit? Finally, after those anticipatory anxiety is built high enough, then you start avoiding situations where if you get an attack, you can't get help, or help can't get to you. And that's called agoraphobia, which is another misnomer. Now, mind you, not everybody goes through all that. There are some people who just get the panic attacks. They don't develop the anticipatory anxiety. They don't develop the phobias. There are some people who get the panic attacks, and they get some degree of anticipatory anxiety and worry. They may go to a lot of doctors, but they don't necessarily develop the phobic avoidances. There are some people who are housebound, cannot go anywhere after the very first attack. So there's a tremendous difference in what panic does to you and how you respond to panic. One has a suspicion that people who develop agoraphobia both have panic and a tremendous potential for developing anticipatory and chronic anxiety. Now, what arrhythmia did was block the panic attack. It did not block the anticipatory anxiety. It did not block the phobic avoidances. Those are a horse with a different color. And that's one of my major points, is that we have to have a splitting attitude towards our generic terms, such as anxiety, but for that matter, depression. So back in 62, 64, we showed that in the placebo-controlled trial, we pointed out panic is not anticipatory anxiety, it's not phobic avoidance, it's not normal fear. If you give a patient a litany, for instance, their ordinary fearful reactions are perfectly okay. They jump out of the way of a car coming, just like anybody else does. Panic and seeds agoraphobia, separation anxiety of childhood, as Maurice mentioned before, is a regular phenomenon. Understand, separation anxiety in childhood is a normal phenomenon. From age approximately 1 to approximately 4, it's common, almost 100%. It's the persistence of separation anxiety to the point of school phobia, another misnomer. They're not afraid of school, they're afraid of leaving their mother. Because we observed the high incidence of separation anxiety in childhood, we decided actually to do a study, first a pilot study, then a placebo-controlled study, working with Klein, on school phobic children. And what we did following Leon Eisenberg was give the kids and the mother both psychotherapy about how the child needs to be in school, how the mother should sabotage this by overreacting to the child's panic. And that works. That works about 75% of the time. You don't need to get on medication in most cases for phobia. You have to deal with the mother's anxiety. But there's about 25% that doesn't work. And those are the kids we studied in the placebo-controlled trial, and it worked. So Anxiety as a term covers an enormous number of features. Now, I talk about spontaneous panic. The person's walking down the street, bang, they get a panic. And people often say, no, nothing's spontaneous. You understand, I'm using the term in the same sense that, you have a bunch of oily rags in a closet, you might have spontaneous combustion. But you need the oily rag in the closet. There are numerous antecedents to developing panic attacks. First of all, it's familial, highly familial, friends and families. It's most prominent in females. There's quite a high ratio. There was always an argument, perhaps, so women are more likely to go to doctors than men, and that's why when you go to a clinic, there are more women with anxiety than men. But epidemiological studies that don't depend upon self-referral have shown exactly the same thing. There's separation anxiety disorder. There's the premenstrual state and the postpartum state. Both of them markedly associated with intermittent panic attacks. As Maurice mentions, personal loss, divorce, death, just moving sometimes. Clinical depression is an extremely important antecedent of panic. As a matter of fact, there are some people who only panic when they're in the episode of depression, but that's not usual. Childhood respiratory disease, that's particularly one. You think that is retrospective. In fact, there's a study in New Zealand where they followed kids up from 3 to 21, and it turns out that childhood respiratory disease is the most potent predictor of panic. Immediately we think like asthma and bronchitis. Because of that, I suggested to Naomi Breslauer, who does epidemiological studies, that perhaps she ought to study the relationship of smoking to panic. It turns out that smoking is a major antecedent to the development of panic attacks. Smoking a pack a day is really very bad for you. We've shown that, working with a group in St. Louis, to be true in teenagers. It's also been shown by studies of lung function that smoking within 3 or 4 years already impairs lung function. Now, I want to make a focused argument against a certain point of view that's very common. That is the idea that a panic attack is simply fear, that it's misreleased fear perhaps, but it's just no different than fear. I argue that it's quite different than fear, and in many different ways. The 3 most common non-psychoanalytic theories about panic attack are those by Warlow Crest, that is conditioned alarm due to a somatic sensations, and one reacts to these interoceptive sensations as if there are signals of something going wrong, and therefore you react in a fearful way. Clark, who started with the idea, believe that it's because the person catastrophizes, that they have a cognitive attitude that this is a horrible thing happening to me, and that leads to a vicious circle, which ends with a fearful business. Jack Mormon and the Doom, they have taken a more biological spin on the thing, saying that the fear circuits themselves, as shown by the amygdala and the prefrontal cortex, are in themselves hypersensitive. So the person is likely to become more fearful for less reasons than most people. Now, one of the most astonishing things about the panic attack, which makes it really immediately different from the ordinary fearful experience, is that if you measure the blood during a panic attack, which we can do now, there is no hypothalamic pituitary adrenal activation. That is, the ACTH, which doesn't go up, the cortisol doesn't go up, the catecholamines don't go up. Everything is flat during the attack itself. If anything, sometimes they seem to go down a bit, which is entirely opposite of the usual emergency reaction you have to a sudden fright. Nocturnal panics, which Maurice mentioned before, when do they occur? Well, one might think they should occur during dreaming, because you all have nightmares, and you would think a nightmare would be something that would send you into a panic. In fact, it never occurs during dreaming. It occurs during non-REM sleep, during deep sleep. As your sleep gets deeper and deeper, it's the most likely time you're going to have a panic attack. And when people describe panic attacks, you say, well, you know, having a dream, I'll tell you, no, I wasn't having a dream. It's just panic. Panic attacks are unpredictable, which is not the fear situation at all. There are certain situations, for instance, a person may know that they're likely to have a panic attack in a supermarket. They've had it there before. So they go into a supermarket expecting to have a panic attack, and they may not. Or they may feel perfectly okay for 10 minutes, and then they get suddenly struck by a panic attack. So again, it's not the kind of tight stimulus binding that one finds in ordinary fear. And of course, when spontaneous is straight on, inexplicable. The means I told you before blocks these full panic attacks. They doesn't block ordinary COVID fear. It's interesting. And that means the drug that we give it has all sorts of side effects. It makes you sweat, gives you fast heartbeat, dry mouth. These are all the things one would associate with fear. You won't expect that if you give a memory to somebody who is unruly fearful, that their fear should go out of sight. They should panic more. Not the case. Not to say they don't complain. Many panics are distressing but not fearful. One very good example is the cardiac catheterization laboratory. Roughly 20% of people who have sufficient problems, chest pain, incapacity to warrant a cardiac catheterization have perfectly okay coronary arteries. There's nothing wrong with that. Bernie Beitner has shown at least half of those people have actually not what he refers to as non-fearful panic attacks. You know, also, again, something created by Freud, what he called larval anxiety attacks, where people got a part of an anxiety attack and it goes away. That's common. People who only get limited symptom attacks. They get 1, 2, or 3 symptoms, they come, they go. People who get full attacks often have horrible attacks in between full attacks. From the point of view of even the fear-type theories or the catastrophizing-type theories, that makes little sense. Why should, if you start on an attack, why should it keep going? The air hunger, which I prefer nowadays to the term dyspnea, or dyspnea, the people feel like they can't get air, they crave it. Is that part of ordinary fear? The answer is no, not really. And there have been, at least 7 good studies of people who've been exposed to extraordinarily dangerous circumstances. They jumped out of airplanes and they shot at on a battlefield. They're disassembling bombs. And what did they experience? They experienced palpitation, sweating, and trembling, which are the hallmarks of that condition. It's not shortness of breath. That's not part of it. A study was done comparing imipramine with alprazolam, which is a high-potency benzodiazepine. They both worked about the same, which seemed to be cockeyed from my point of view. But then the British psychiatrists were able to analyze the symptomatology of a panic attack by using cluster analytic method. Now they found essentially was that everybody reported palpitations, sweating, and trembling pretty much, but only something more than half of them reported intense air hunger also. If you split them, the ones with air hunger, the ones without air hunger, the ones without air hunger, the benzodiazepines were actually better than imipramine, but the ones with air hunger was clearly better than the benzodiazepines. So again, we have a splitting issue here. And there are panics, and there are probably also panics, you know, all the same thing. Now, the progress of science has largely depended upon our ability to experiment. Naturalistic observation is terrific for developing hypotheses. It's not terrific for testing hypotheses. Most of our psychopathology is outside of our experimental control. Panic, peculiarly enough, is not. We can turn it on with particular challenges, and we can turn it off with particular medications. Therefore, it lends itself to a great deal of experimentation. It turns out that There are a number of substances that are very unpleasant. EPA, which causes muscular spasm, insulin, tryptophan, isotretinoin, all these things, when infused into normals, cause a lot of distress. And when infused into panic disorder patients, cause a lot of distress, but does not cause panic. Conversely, intravenous sodium lactate, when infused into normals, causes rather little. But when infused in patients with panic disorder, about 70% of them will panic. Similarly, inhaling carbon dioxide. If you inhale carbon dioxide, a normal person will feel their breathing is being stimulated, because it's the most powerful respiratory stimulant. If we have about 5% carbon dioxide in the lungs, if you put somebody in 5% carbon dioxide, they're in dynamic equilibrium, they're breathing in as much as they're breathing out. Again, the normal person experiences some respiratory stimulation. The panic patient, not immediately, but maybe after 10 minutes or so, will have a panic attack, again, about 70% of the time. That particular thing is highly specific. You can give lactate or carbon dioxide to other anxiety disorders, social phobia, obsessive-compulsive disorder, doesn't happen. So we're talking about a rather specific vulnerability. Another peculiar thing, the panic attack itself only lasts 4 minutes. The patient was shook up for a longer time than 4 minutes. But if you actually measure the physiology of the thing in terms of the respiratory disturbance, it's just 4 minutes. So what happens to it? We can discuss that later because it's complicated. Panic disorder waxes and wanes, so it's probably not a temperamental variation. With women, as I told you before, premenstrually, even postpartum, there's a marked increase in panic attacks. Well, what about during labor and during childbirth? And those are periods where you are flooded with extreme unpleasant sensations. You're actually in increased realistic danger. One might expect, on the fearful hypothesis, that panic will be common. In fact, panic never occurs during labor or during childbirth. Now, why should lactate and carbon dioxide be important? As it turns out, they are both signals of impaired respiratory function. If you asphyxiate an animal, the very first thing that happens is the brain lactate goes up. Similarly, if your carbon dioxide level is going up, that means you're not getting rid of your carbon dioxide, so there's something wrong with the respiratory system. So you have a situation where both of these pathogens are also signals of respiratory problems and deficiencies. Now, has that been extended to children? Dan Klein down in IMH right now has done terrific work on studying carbon dioxide sensitivity in children. And it turns out that anxious children are carbon dioxide sensitive. I'll show you some pictures shortly. But if you divide up your anxious children into socially anxious, the two major things that anxious children have are either social anxiety or separation anxiety. And it turns out that the carbon dioxide hypersensitivity is limited to the separation anxiety group. It's not within the social anxiety group. So again, we have a splitting of anxieties. That's the lactate infusion. If you look at it, what we're measuring here is tidal volume. That's the amount of air that goes in and out in any single breath. Here's a breath-by-breath recording. Each of those spikes in breath. You can see over here there's one very big spike. That's sighing. Sighing is well known to be part of anxiety. Okay, that's a sign. Here you can see on a single breath, the person is all of a sudden hyperventilating, and this is the point, the 0 point where they report panic. the hyperventilation actually antecedes the panic. That's peculiar. But that means hyperventilation causes panic. No. Because if you tell people to hyperventilate, they don't panic. They get very uncomfortable, they don't panic. Hyperventilation actually is part of panic. The panic process includes hyperventilation. These are Dan Klein studies. These are children exposed to carbon dioxide. These two slides over here are normal kids. You can see what's happening with their breathing goes up and comes down with the carbon dioxide exposure. These anxious kids, you can see extremely irregular, very jagged, extended, vocal sign respirations over here. So that you have a great similarity between separation anxious kids and panic disorder in that sense. We also measured people walking around with an ambulatory measurement device. This is one example. There's an old gadget, we have much better gadgets now. What this is doing is taking an average over a 2-minute period of tidal volume. This here, we're measuring respiratory frequency. That is how often during a minute the person is breathing. You can't see anything much, frankly. I go here with discombobulated, but it's nothing much. But I want to look at that arrow. If we look at tidal volume, you see this terrific spike at the point of panic. You remember these are 2-minute averages. A third panic attack lasts about 4 minutes. So that's what we have here. And that's well replicated now. Nocturnal panic. This is a well worth paying attention to. Look at the time frame here. This is an hour from here. So here we are around 10:30, the person is asleep, we're measuring tidal volume. We can see that the tidal volume is very irregular and it's going down, which is quite usual. Tidal volume decreases with breathing or with sleep, which means, by the way, that your blood carbon dioxide is probably coming up some. So that's not to measure here. At this point, which is a full hour and a half of this, the person gets into irregular gasping respirations. They are taking deep breaths and sighs, and they're obviously in some sort of respiratory trouble. And at this point, they have a panic attack. So that anteceding the panic is while the person is asleep and no dreams, they're having ample evidence that respiratory difficulties are an intrinsic part. This is probably more than we need to go into here, but basically what I'm saying is that we have a number of different substances that people claim can cause panic. These are lactate, bicarbonate, carbon dioxide, isoproterenol. But there are a bunch of other substances here that have also been claimed to cause panic. What's interesting is that all of these substances can be blocked by imipramine, and these substances cannot. These substances often make normal people panic, or at least have panic-like symptoms. These substances don't. These substances do not result in hypothalamic pituitary adrenal activation, and these substances do. So we've got probably evidence here, at least 2 different kinds of pathological response that won't get confused. And as I told you before, if you have dyspnea under breathlessness, you're more likely to respond to dopamine than to Xanax, and conversely. Why shouldn't the hypothalamic pituitary adrenal situation be activated? How do I put this all together? I think that everybody has a suffocation alarm system. That just like we have a hunger alarm system or a thirst alarm system. And that, like any alarm system, it can go off too easily. And I believe the panic attack is essentially that the organism is acting as if it has suddenly received the message that it is suffocating when that's not the fact. But anything that gives it that sort of clue, such as fluctuating carbon dioxide or lactate, will set the thing off. If you are actually actually suffocating, does it make sense to have a hypothalamic pituitary adrenal response? Because what that actually does is to throw you into oxidative high drive, because you want to burn your fuel, because most of the time that's a predatory situation and you want to get the hell out of there. But if you're actually suffocating, it doesn't make sense to go into hyperoxidative high drive. How do you pitch that out? Not easy. Most of the studies of asphyxiation in animals, those animals end up being measured on their terminal, their agonal, their throes of death, basically. The best example is during sleep apnea, because people go stop breathing while they're asleep, and you can measure cortisol continually during the sleeping. And during the period of sleep apnea, there is no increase in cortisol at all. All chemicals into the matter. So that the mere experience of at least temporary suffocation is not in itself an HPA elusive. Panic treatment. There are lots of things that are not effective and lots of things that are effective. The things like ECT, because some people go in panic with a type of depression. ECT is terrible. It works negative anything. The protein doesn't work, the propion doesn't work, Disprone doesn't work, propanol doesn't work. Low potency benzodiazepines don't work. Kathy Shear has done some work in emotion-focused psychotherapy that brings it into work. Relaxation makes things worse. One of the things that are effective, tricyclics are effective, and they own inhibitors, SSRIs, high-potency benzodiazepines like Xanax, Klonopin can be effective. Perhaps non-directed therapy, again, it's studied by Kathy Shear. Cognitive behavior therapy, there's a big argument about. The best study has been by Barlow, Foreman, et al. And if they use a measure which is like a coarse measure of global improvement, in their study they found that dopamine and CBT were about the same. However, if you use a focused panic measure, and you compare those who were claimed to be responded to CBT and those who claimed to be responded to amphetamine, the amphetamine patients plainly have done better, much better than the CBT. So that a lot depends on how you define improvement. As I said before, the panic phenomena, a whole complex of things, the panic attack itself, the anticipatory anxiety, the degree of avoidance. Anticipatory anxiety and avoidance often respond to psychotherapeutic input and having a strong ally who tells you what they think is going on. I think that's what the global improvement scale is picking up. But when you focus on panic per se, it's not obvious that CBT is so effective. This sort of repeats what we've been saying about carbon dioxide hypersensitivity. And also interesting that there's a familiarity that in the carbon dioxide sensitive patients have more of a family history of panic disorder than carbon dioxide insensitive ones. This is the stuff I told you before about children. And there's one other split here, which is really interesting. Dan Klein showed that it was the separation anxious kids who were carbon dioxide sensitive. He hasn't published this yet, but I think one might mention it. In a much more elaborate study, he also studied the parents. And it turns out that he studied normal parents, depressive parents, parents with panic disorder, and their children. And it's true that separation anxiety makes you more sensitive to carbon dioxide if you have parents with panic disorder. But there are lots of kids with separation anxiety that don't have parents like that, and they apparently are not sensitive to carbon dioxide. So even within something that seems as simple as separation anxiety, we probably have at least 2 or 3 conditions. Finally, one more thing. If there's such a thing as a suffocation alarm system, how do we know that we've got one? Well, the simplest way to know is that people don't have one. And that's true. There are children who have called congenital central hypoventilation syndrome. These kids, they're born, they're painfully healthy, they put them in the nursery, they seem all right, they go to sleep, and they stop breathing. That sounds like sudden infant death, but it's not, because if you shake them awake, they start breathing again. And let them go back to sleep and stop breathing. while you're asleep, carbon dioxide is the almost sole driver of respiration. If you're carbon dioxide insensitive, you're not going to have your breathing driven. And that's what these kids have. They're carbon dioxide insensitive. They're kept alive now by various forms of mechanical ventilation. When you expose them to carbon dioxide, they have no increase in respiration. They have no feeling of suffocation. They can't be woken up by it, interestingly enough. Again, maybe yet another alarm system in. Pfeffer, I think, down-regulates the suffocation alarm system. These kids aren't getting any suffocation alarm system at all. Pfeffer will actually impair their breathing. It will actually cause apnea. So therefore, you've got another evidence that what the mechanism of Pfeffer action might be. So that's when we came up with the suffocation false alarm theory about 10 years ago. And that, I'm just going to review it for you, that a panic attack is a suffocation alarm going off, triggered by indicators that perhaps you're not getting enough oxygen, you might be suffocating. And that the interesting thing about one of the things that's important in us in our handling patient is smoking and respiratory disease is very important. And as Breslau showed in her epidemiological study, among those who smoked and were able to stop smoking, the incidence of panic disorder is much less. So that we don't have apparently a permanent lung damage that we're dealing with here, but a reversible impairment of respiratory function. So if your patients are smokers, that's something you really have to pay attention to. And I think at this point I'll turn it over to Maurice again.
Here are a few useful notions of endogenous opiates. Capsules are the predominant temporal transmitters. Endorphin cleaved from the pituitary POMC. Pro-opiate is the major circulating endogenous opiate. There are three major classes of receptors: the mu, delta, and kappa receptor. Novel receptors are constantly discovered. Almost every 2-3 months there's something else, or a sub-receptor. And that's my favorite. Humans, just like plants, produce morphine and codeine. Opioids in the control of breathing. A few notions to keep in mind here. Endogenous opiates are activated in low oxygen and high carbon dioxide induced respiratory distress. So I think by the time we're done here, everyone will have a rise in opiates. Opiates decrease respiratory sensitivity and increase adaptability to low oxygen environments. Opioids increase survival under hypoxic and hypercapnic high CO2 conditions. The clinical application of this is that nebulized morphine can be used for the treatment of chronic dyspnea. Now, one of the most fascinating and clinically useful discoveries of affective neuroscience, endogenous opiates and exogenous opiates are also involved in the physiology of separation and reunion. The way this was first discovered by J.P. Scott and Jaak Panksepp in the early 70s, and subsequently confirmed by many others, was through the study of the separation call of young animals. In other words, one can experimentally separate young animals from their mothers. They will appropriately protest and emit distress calls that can be quantified. The more isolated the young animal is, the more distress calls per minute it will vocalize. These separation calls can be specifically blocked with morphine, as well as with imipramine, the endopanic medication. On the other hand, the administration of the opiate blocker naloxone will intensify these separation signals. This slide is taken from Panksepp's book, Affect and Neuroscience, that many of you will be familiar with. You can see here that the intensity of the separation distress and the amount of morphine needed to block it differs in this case, purebred beagles versus hybrids, but it's of course true in other animals and probably in humans as well. To summarize, the endogenous opiate system is activated by positive social interactions ranging from mutual grooming in young animals to sex. A low but not a high level of opiates increases motivation to seek social contact. And opiates attenuate the reaction to social separation. Putting it all together, this is the expanded version of the suffocation-Fonsalon theory. Opiates, such as morphine, specifically decrease both separation anxiety and sensitivity to suffocation. Naloxone, the classic opiate receptor blocker, exacerbates the separation reaction. So the original assumption that spontaneous panic attacks are due to a hypersensitive suffocation alarm is expanded, based on what we've heard so far, by the hypothesis that the basic biological defect in panic lies within the endogenous opiate system. How did we test this? Again, we assume that normal subjects are protected by a functioning endogenous opiate system against lactate-induced panic attacks, the kind of experimental challenge you've heard about, and that triggers a full-blown panic attack in people with panic disorder. So we were wondering, what if one used the classic opiate blocker naloxone before lactate to normal people to temporarily disable their putatively intact endogenous opiate system? We have normals, they don't panic with lactate, or very rarely. And if we give them naloxone to block their endogenous opiate system, what happens? Well, that's the hypothesis. They will panic, or some resemblance of it. After a small pilot study by Sinja had yielded promising results, we designed a randomized study with normal subjects to definitely test this hypothesis. Subjects are healthy, normal, male and female adult volunteers that are not affected by any psychiatric or medical condition. We also have a very long list of questions about anything in the subject's personal and family history that may be relevant to panic and separation, and may consequently influence their response to the lactate challenge, including traumatic separations in childhood, traumatic separations in the parents and in the grandparents' generation, childhood respiratory disease, near drowning events, migraine equivalents, car sickness, cyclic vomiting, or real migraine in childhood, and PMS. The subjects were originally randomized to 3 groups. They received either lactate preceded by naloxone, or lactate preceded by water, meaning lactate alone, or naloxone alone, to rule out a respiratory stimulation effect caused by naloxone alone. We showed that naloxone without lactate had little respiratory effect, which made the naloxone saline group, naloxone alone group, superfluous. This is our current design. So we're comparing now lactate preceded by naloxone with lactate preceded with water, meaning nothing, to see whether temporarily blocking a normal endogenous opiate system with naloxone allows lactate to bring out the panic effect. This is our current design. The same subject receives two separate infusions on separate days of naloxone lactate on one day, and saline lactate, which means lactate alone, on the other day, under randomized double-blind conditions. To measure effects, we're using a gadget called the live shirt. This is our latest gadget, and that's how it looks like from the company's website. He's too old for our study. The live shirt uses a built-in electronic sensor system to record respiratory and cardiac function. This is how it looks like after the data are collected and uploaded to our PC. Let's spend some time on this slide. Basically, this is a very expensive but also very nice gadget where you can play around with multi-channel recording of rib cage expansion, abdominal breathing, EKG, and many others. And you can change the window. This is a 1 hour window. This is basically when things happen within that first hour. And then we keep them for 3-4 hours to make sure they wash out the naloxone before they go home. Now, what we have here, these are markers put in when the infusion starts. This is the first infusion, the second infusion. This is the baseline period. We give them, again, we don't know what's in there, but it's either naloxone or water. Over 3 minutes, we wait 20 minutes, and then we give them the lactate. This is a very typical graph that shows a significant increase in target volume and respiratory rate during the second infusion. What is the subjective experience with these infusions? As I mentioned, there are no major respiratory effects when you block the opiate system with naloxone in normals. What's of interest to the neurologists is that we had a handful of subjects who described typical migraine auras with naloxone, and that's one of them. We asked them to draw them. They were colored and original. Also, many subjects will derealize, if ever so briefly, with naloxone. One subject described his feeling as if her head was in a fishbowl. With the naloxone lactate combination, one gets a lot of transient respiratory distress, chest discomfort, and all-out panic anxiety. Very verbal subjects will precisely describe how difficult it is to differentiate semantically between the very physical feeling of chest pressure and of air hunger, and the affect of anxiety. The physical and the emotional seem to converge, become one at some point. And this is what our statisticians tell us. This is a preliminary look at the second infusion. These are group effects. All people are put together. The X is not working anymore. So here you have time, starting with the beginning of the second infusion, time in seconds, and this is time volume, air in and out of the lungs per breath. Lactate alone is in red, and lactate preceded by naloxone is in blue. You can see here that not much happens in the beginning of the second infusion, and after about 10 minutes, 600 seconds, there's something that happens a little bit in the lactate alone group, but basically there's a crescendo of tidal volume in that group that had naloxone before the lactate. The difference between these two groups is highly significant statistically. These results support our hypothesis that naloxone pre-treatment makes normal individuals who have an intact opiate system vulnerable to lactate and provokes a reaction that is very similar to a clinical panic attack. In other words, we now have an experimental model of the clinical panic attack in normal subjects. Where do we go from here? One logical step would be to further validate these results. and for instance, to see whether this effect can be blocked with standard anti-panic medication. By way of conclusion, our theory provides a framework connecting panic data to endogenous opioid dysfunction, separation anxiety, respiratory and pain vulnerabilities, thus amplifying the suffocation false alarm theory. We propose that panic, separation anxiety, and related conditions, such as premenstrual dysphoria and certain pain syndromes such as pseudoangina, pseudo-chest pain, and migraine, may be due to a disturbance of the endogenous opioid system that adaptively regulates respiration, separation anxiety, and social affiliative rewards, in addition to pain. Genetic and epigenetic vulnerabilities and later life events may affect endogenous opioid function and modify the suffocation alarm threshold. Loss, grief, and massive psychological trauma may lower this threshold, causing anxious symptomatology as well as heightened panic vulnerability. A strength of this theory is that it explains many at first sight unrelated facts across several domains, none of which are deducible from an associative fear theory. It is not a simple physicalist hypothesis, but provides an integrative matrix for complex developmental, psychological, and environmental phenomena. Further refinements are necessary to address the gastrointestinal, headache, and vestibular symptomatology of separation-anxious children and some adult panic patients. Migraine headaches are highly comorbid with panic and share the epidemiological, psychological, and neuroendocrine features of panic, provides the basis for integrated research. Our hypothesis is sufficiently concrete that falsifications, amplifications, and modifications are possible. Should we all take a deep breath?
I actually spent 2 years at the Public Health Service narcotic hospital in Lexington, Kentucky, running the admission withdrawal unit. One of the things we tried to look at was what's the incidence of panic attacks in people who maintain on methadone. But one would think that the people who maintain on methadone would really be blocked against panics. Unfortunately, first of all, the data is not terrific. Second of all, because cocaine is a powerful pathogen, even if you're on methadone. And many of the people who are on methadone are also, every once in a while, giving themselves some cocaine. So that, unfortunately, it's a blurred situation.
We've been discussing this for the longest time. It's a very interesting question. There's a literature in the family systems literature. I'm walking in the name now, I had it in the expanded talk, that claims that data from the 50s, 60s, and I think it's clinically true, show that opiate family, and this is a systems theory, so they look at families rather than individuals. There's a theory that there's one opiate addict in the family who basically is the designated opiate dependent and who acts out the general context of loss in the family. I think clinically it works. I don't know how good the data are, but it's a very interesting theory. We disagree on this, but I think it works in some cases, and it's good to look for it. Yes, that was another.
Two questions. Why do you think the high-potency benzos work with panic attacks if the HPA axis isn't involved? And the other was, I'm not sure if I missed this or not, but is there a higher incidence of panic attacks with people with apnea? And has that been measured in any of the sleep studies, that sort of thing?
The question about the high-potency benzos, I don't have a good answer for it. I think that there's at least some evidence that high-potency benzos are working on other systems besides the straight-gather system. And a fellow named John Chernatsky one time published data to this effect that there's a set of receptors, the sulfuride, which is a type of computer antidepressant it interacts with, that the high-potency benzos also interact with. But that did not get followed up, as far as I know. And I can't give you a good answer. As to whether people after they walk in, the closest that we have to that is people with chronic obstructive pulmonary disorder. And the most common psychiatric illness is panic attacks.
First of all, I want to say that your work is really broad-ranging and wonderful. It's a wonderful, large set of hypotheses that I think are very exciting done. It's thrilling to see you here as a member of this institute. What I wanted to say, one of my grant reviewers at the NIH tells me that my job is to translate, that I'm doing translational research from psychoanalysis to the rest of the world. And what I wanted to say about this theory is that, in fact, the hypothesis about real respiratory downregulation or sensitivity in panic patients actually goes along with a whole bunch of what, is this mine? What do I do? It goes along with where you started, Maurice, with the studies on hysteria, and it goes along actually with a psychoanalytic view of panic disorder. You know, if we look at panic disorder from the perspective of psychoanalysis, it's basically in the category of conversion disorders. And what Freud said is that there's somatic compliance, and in fact clinically this is frequently the case, you know, in working with conversions, that there is this core biological underpinning to then this elaborated psychological disorder. And so this theory is actually very exciting to a psychoanalytic researcher. And I just wanted to say that.
I'd like to echo what Dr. Millman has just said. You know, this is my first, I guess we call it neuropsychiatry meeting I've come to. I've avoided them. I'm a psychologist and a psychoanalyst. What's prompted me to come here is my patient with a panic disorder. And I'm thrilled that I came because unlike what I thought it was going to be, it's so connected to psychoanalytic thinking and understanding. I'm getting acne, I can't breathe. But anyway, I'm a little bit nervous. But
don't blame it on yourself. I think the information is maybe probably CO2 is probably more than 5%.
I didn't hear you. What did you say?
I said don't blame it on yourself and your anxiety. I think the CO2 content of this room is probably going up fast.
Okay, but I know it. But what I have several questions, and what, you know, a couple of statements. One is, can you die from a panic attack? I need to know that for my own sense of whatever, you know, and working with this man, who I've been working with for 7 years. As he's become more psychologically minded, which he has, I can't say his panic attacks have gotten worse, but he's had a couple of very severe ones, both in his native country, not in this country. He had his first panic attack after about 2 years of migrating to this country, and then went to a psychiatrist who he saw and who gave him Paxil and Klonopin. But he was dissatisfied because the man didn't talk to him. So he's looking for someone to talk to. He didn't want cognitive behavior therapy because he doesn't like people to tell him what to do. So he looked for a psychoanalyst and he came to me. And he's been challenging and wonderful to work with, but also scary because it seems like he's gotten more agoraphobic in the last year. And so his sphere of he can't go back to his native country at this point yet. Anyway, and I think maybe this is just the interim period. He has stopped using the Paxil about 2 years ago. He doesn't like to use medication, and he's upset about the fact that he has to use Klonopin. So this is his, but he's also suspicious about, is psychoanalysis really working? I guess what I'm asking you, and I think that working on understanding this man from both points of view could be fascinating revelation. What I'm asking, I guess, is would the combination of some kind of opioid with the psychoanalytic treatment be something I should recommend? And I guess I said enough.
The idea of using opioids as a treatment in this country raised to the hackles of the federal government and the DEA in particular. And, even for cases of severe chronic pain, there has been some considerable reluctance upon many doctors to use opioids because of their fear of being considered as people who are supporting an addiction. Recently, a new group of opioids has come out. One in particular, the drug called buprenorphine. Buprenorphine is a mixed agonist and antagonist that has an integral property that at least one can orally. It will act as an opioid, but it also has antagonist properties. So when you take bigger and bigger doses, it actually turns itself off. So that it's almost impossible to get hooked on oral buprenorphine, though it probably is possible on intravenous. It raised a very nice question. Would it make sense to do a trial on a drug like buprenorphine in patients with panic disorder in a controlled way? It would make good sense. That would be very difficult to get funded. But I think that there's sense to the question, but right now we don't have a good answer. The other thing I want to point out is that panic disorder is a waxing and waning illness. It comes and goes on its own. Any condition like that is a problem in evaluating therapeutic effects because you're never quite certain when the person getting better is it due to you or is it spite of you for you. So that's why we need controlled and comparative trials for that sort of thing.
The only way to get opiates right now for panic is, I'm saying this with a little facetiously, but not very. There are a few studies not done in this country that show that running exercise treat panic quite well. It takes time for that, but it makes sense in the context of the endogenous opiates, run is high, and I think it really works quite well, and it's certainly the safest way of treating it. But it takes time. So if someone is dissociating in your office and can't work in psychotherapy, can't work with anything, you have to do something about it, and that's usually, the first order of. But there are many ways of treating panic. Thanks for your question.
So the gentleman in front of the last question.
I was wondering what the implications are for psychotherapy, given the research presented. And related question is, some patients do get better when we treat them, and I wonder whether there are physiological correlates of that.
It's been very little research. There was one bit of research that we actually did, and I'm not even sure it's published. In that study I mentioned before by Morrow, that was done at 4 different sites. One was at PI, when Dan Corman was running it, and patients who have panic disorder are frequent chronic hyperventilators. I think that's true because that way they keep their blood carbon dioxide low and is unlikely to trigger the suffocation alarm system. It's been studied very carefully, and when you say somebody's a chronic hyperventilator, actually it doesn't mean they're breathing fast and deep all the time. What Frank Wilhelm has shown is that it's simply that they sigh much more often. And each sigh counts like 3 deep breaths, and that's what does it for them. Well, we measured the PCO2 level, the carbon dioxide, the person's expiration, when they came into the trial. And the usual carbon dioxide level, forget the units, is 40. People came into the trial were around 35. We then looked at them in terms of their responders. The people that responded to CBT and apparently gotten better when they were receiving CBT, their carbon dioxide was still at 35. The patients who responded to the liver meeting, their carbon dioxide was about 40. Does that mean anything? I'm not sure. To be sure that meant something, you'd have to show that the people who had normalized their carbon dioxide were at less of a chance to relapse than the people who had not normalized their carbon dioxide. That's never been done. So I can't really give you a very good answer about that. What are the implications of psychotherapy? I think the separation anxiety motif is very important. And I think it's very clear that patients like this will often form very strong, sometimes dependent bonds on their psychotherapist. And it's a headache insofar as we're trying to foster independent living. What does that mean? So you focus on the fellow, by the way, who's probably closest and is thinking about this thing living out of Arnold, actually. Rock decided the way to handle it was by fixing a termination date when you start. And then you spend the rest of the therapy discussing the patient's reaction to the termination date. The other possibility is not having a termination at all, but using booster sessions. And you do therapy, and the person is doing better. At that point, you start more and more infrequent sessions until eventually once every couple of months. That might work too. I'm not saying it does. That's the implication of I see.
There's content, and some of you may disagree with this. If you put this into the context, we've been discussing it for an hour or over an hour. It's helpful if you address, perhaps not in a very neutral psychoanalytic way to begin with, that there's something that happened to these people many times, and sometimes you have to ask, you have to give permission for them to tell the story, and this goes a lot into trauma, but this is all dimensional. It's not totally separate, obviously. I think this is key. If you address in your patient what happened, I don't know what the context is, but it sounds very, very traumatic and dramatic to Dr. Katz's patient. This is very helpful because perhaps for the first time there's someone who actually puts this into a meaningful context. So this is the beginning. At the same time, what I do, I use medication obviously because you have to help them feel better soon, and then you go from there.
I wanted to add my congratulations to the presenters. It's a wonderful piece of work, and it really enhances our information base and knowledge a great deal. But unlike the other Dr. Miller, I'm not a researcher, and I'm going to make some comments from the psychoanalytic point of view, which I'll later try to correlate with the data presented here. First of all, the presenters did mention a number of times developmental issues, and I want to touch on developmental issues from the psychoanalytic point of view in terms of separation, what we mean by separation, and anxiety and panic. Because separation means many different things, and it's often presented by inference or with innuendos or with lack of clarity, as though it's one phenomenon. And I think that one has to take into account the development of what analysts refer to as the maturation and development of the psychic apparatus, particularly the ego and its functions and its structures, to understand what separation means. Because before differentiation between self and object images, separation is very different from what separation signifies when we have differentiation and the level of object constancy established. Because there are many ego substructures and functions in place by that time. The individual with a structured, mature ego will certainly react to separation, but their way of dealing with it will be much different from someone with an unstructured ego or a minimally structured ego. And this touches on anxiety and panic, because I think it was last time we were talking about the subject of anxiety, and there is more than just one anxiety. Freud talked about traumatic anxiety and signal anxiety. And signal anxiety is something that an individual can develop only with ego maturation and ego structuralization. When there is enough memory, enough of a function of anticipatory function, and enough understanding of cause and effect, and enough understanding of the reality world, so that the individual can anticipate potential danger from within or without, and produce a signal of anxiety, which then institutes defensive measures. Earlier, in a less structured ego, there is a tendency to be overwhelmed by the danger, and that is what we're talking about in terms of panic. And I was interested in the references that Maurice made to the vulnerability to separation, meaning that there's a variety of vulnerability. I think that's alluding to the variety of people that present themselves with anxiety problems measured by the structuralization of the ego and the degree of ambivalence that Maurice mentioned in some patients when we're talking about loss of a critical love object, that it affects the degree of pain. And similarly, the centrality of breathing in this whole phenomenon takes us back to a very early time of life.
Centrality of breathing or grieving?
Breathing. Breathing. It's such a central issue. The dysfunction of the anticipatory function that I think Don mentioned is also an element that refers to an unstructured aspect of ego formation. So we're dealing with degrees of maturation and structuralization of the ego. And I would say that it raises the question, since there's a dysfunction in your hypothesis of the opioid system in panic disorders, is it possible that there is some relatedness between the dysfunction of the opioid system and an immature, unstructured, not fully developed ego structure. And that with more ego structure established and stable, that the opioid system becomes more functional and effective. One of the things about treatment is that I think one thing that has not been touched on is that if this has any validity, that one aspect of analytic treatment or analytic therapy treatment would be aimed at building ego structure. And that's a different thing. And it takes much more time than undoing conflicts that are unconscious.
A lot of what you say, we're in perfect agreement with. I don't think one of the points I was trying to make was that there are many different sources of anxiety, and there are probably different sources of separation anxiety. And we've also pointed to that the normal development of a child is a period between age 1 and age 4 with undevelopment what's going on there from point of ego development. The separation anxiety is quite usual, and that with growing maturation, that the vast majority of people disappears. So I think we have a big agreement there, except for that terminology. Now, with regard to whether you have a quote ego defect in people who are likely to be overcome by panic, there I think we probably do disagree. And the reason is this, that many of the patients that come down with panic disorder in later life have been high-functioning adults in many aspects of their life. They had a family relationship, they do their work, they raised children successfully. And it's not a hint of a problem in terms of peculiar perception, peculiar ideation, peculiar cognitive constraints. So that it's really expected that opioid deficiency, or just the plain possibility of developing panic attacks, reflected ego defect, I'd be a little surprised. I mean, my understanding of ego defect is pretty primitive stuff. That you're really having a person who's had trouble with their boundaries, with their perceptions, with their understandings. Not my experience of many people with panic disorder. So I think that it may be that you're talking about some people that you see who are dominated by separation anxiety, seems really healthy in an unrelated fashion. That's a real thing. There are people who their separation anxiety just never goes away, and even are treated pretty in many different ways. I think a lot of apparently different views of our patients stems from the particular sample of patients we've seen, and she was different than I have.
I just limit my comment to saying that I think a lot of this is actually semantic. It's semantics, but as you said earlier, it's about how you define certain terms. There's no, I don't disagree with most of what you said at all.
Yes, this is really about the naloxone and the aura that was produced by it. Now, was there a headache that accompanied it? As a long-standing migraineur, I'm very interested in this, and as someone who's had lots of auras.
The one I showed you is the young man whose father is Japanese, and the father's family has migraines. He does not have migraines. The father also lost his mother in a bombing raid during the war.
You want to develop that further, or?
I'm not sure.
Okay, all right.
But I think but there's a migrant context to answer the question, not in this subject, but in the family.
I wanted to ask about the non-dysnic panic attacks and whether that might be related to a hypotensive alarm or having thought of some other kind of alarm system that's involved. Secondly, some of those patients at least seem to vary with their level of depression. That is, that they tend to develop it out of a depressive state, but when their depressive state is improved, it doesn't happen. and they seem to respond to the later generation antidepressants, the SRIs and bupropion. And is that an indication of anything, or do you disagree with that?
That's a complex question, and I think we certainly agree that people will often panic when they're depressed. Some people's panics are limited to being depressed. But the SSRIs are effective anti-panic drugs, absolutely. And that's been well shown. The mention of the appropriate levels of provocative that I don't believe that's been shown.
I would disagree with that. Make some words.
Yes, the appropriate I find is actually making it worse. The other question about, is there other speculations about the non-respiratory kind of panic attack? There are a lot of them, and none of them that I find overwhelmingly convincing. There's clearly some evidence of vestibular disturbance in some patients. It's not clear at all whether that's primary or secondary to the anxiety. Although these disturbances have been described now for maybe 20 years, nobody ever shown they go away when the panics go away, or vice versa. So it's really obscure what's going on there.
No.
And the other thing I just want to mention is the resemblance to social anxiety. That is, the socially anxious person on the spot develops what's very much like an ordinary fear reaction, in the sense that their outstanding symptoms are palpitation, sweating, and trembling. Palpitation, sweating, and trembling are not this new. What happens in ordinary fear and what happens in social anxiety. The non-respiratory panics also are marked primarily by palpitation, sweating, and trembling. There might be some overlap with social anxiety mechanisms. I think it's quite possible.
Talking about, maybe you want to clarify what the non-listening panic, what are you exactly referring to? Because I really like Barbara Miller's courage to call panic conversion, or put it really into what I think we're in for, or there's a need for a nosological reformulation of all these things.
I just wanted to say that I think one of the problems in allying, in psychoanalysts being able to converse more effectively with neurobiological researchers like you guys is the fact that so little of psychoanalysis has been adequately operationalized. So,
that's not true.
Okay, I'd like to see your data. In any case, so for example, this comment about ego deficits and ego psychological sort of levels of development, and how does that relate to this? I mean, I think these are potentially testable hypotheses with a well enough operationalized way of testing ego deficits. I mean, I think that Peter Fonagy's work in reflective function comes close to being able to actually operationalize it, though it's not precisely what they're talking about. But I do think that, you know, language is a problem and precision is.
Just wanted to say, answer your question. The group of patients that I'm suggesting are people who largely have the fear that their heart's going to stop, catastrophic sense of dying, or passing out and dying, without dyspnea, without respiratory remnants.
I usually end up in cardiologist's offices.
It was a very clarifying presentation, particularly the interconnection between the search for specificity of a phenomenon and at the same time its relationship with connectedness with many other aspects of biological or psychological phenomena. What we encounter very often, we are early clinical, as you well know, is what we have considered to be a panic reaction in connection with the disorganization of ego. pre-psychotic disorganization. And you see this coming. There is no forerunner. It may disappear later on in life. It may repeat itself. It has its own connectedness with a certain degree of physiological and psychological phenomena, which are strictly connected with the inability of coping with a phenomenon which threatens the mental existence of the psychological existence. Now I wonder to what degree you have not included this, or ipso, or ipso in connection also with the separation reaction, because one would say the separation reaction, as a reaction, when you really speak about anxiety, when you make a difference between these two, what is reaction, what is anxiety. It is really not so much the presence or absence of the mother or the father. It is the inability of the internal life of the baby to deal with that kind of separateness. And therefore what we really speak about so much is not the separation, but more individuation and the internal capacity of maintaining a certain integrity. Around that, there is a beginning panic response with some. But the panic response in connection with disorganization of the ego is such an important one in the life of so many of our patients. And I didn't hear you responding to that from the viewpoint of your either terminology or from the viewpoint of your therapeutic intervention.
You know, I do think that one of our problems is terminological, and that when we use the term ego, I'm sure it's perfectly clear to you, but not necessarily perfectly clear to you. And that's a real headache, because ego is, I remember the term, I was saying stuff, we refer to a quite enduring set of attitudes, drives, defenses, and that insofar as you talk about ego instability, as you mentioned the term pre-psychotic, we're talking about somebody who's really in very serious trouble, and one would expect that they would have the things that go on pre-psychotic people, such as hallucinatory behavior, quasi-delusional ideas, and you don't see that. You really don't see that. So that I think we're probably not on the same page. That you're referring to in terms of ego problems. It's just different than I understand ego problems. And it's one of those questions to find out if we can find some common ground and understanding what you're referring to. But right now, we're not really talking the same language.
I think some people see sicker patients, and it's not just observational again. There's a small literature on psychotic panic disorder. There's such a thing. I've seen it, you've seen it, many of us. It's transient. It doesn't mean these people become schizophrenics, although in many cases they're called schizophrenics, and if they're in the wrong context, they're still called schizophrenics. I've seen it, not far from here. But they're not on Long Island. So this, and also going back to the study, if you give naloxone to certain people, and it's hard to speculate, it's really a speculation, how they're different. And some of these people will tell you, and they're normally DSM for normal subjects, they feel very, very, very bizarre on naloxone, but only very briefly. The migraine stuff is, of course, the most dramatic and for me, most interesting, but people feel like they're really not themselves. They feel like they're being lifted up for 20 seconds. They don't get very worried because they know they're in a safe place, but there are lots of sensory things that happen with an naloxone infusion. And also, not to make it even more complicated, but the naloxone we're giving them is the highest naloxone dose that is ever given to anyone in this world. We give them 2 milligrams per kilogram. Who is that? We have to look at that. It's a pretty high dose, and we've done, I don't know, 50 or 60 or a lot of people. And then at some point you get into this whole business of which receptors you're blocking at that high dose. So it's complicated. But yes, I think there's a psychotic expression or near-psychotic expression of panic disorder.
When I was in the training institute, I had to do a lot of, as part of the training, diagnostic intake interviews. And the most puzzling feature was the ear hunger and the chest constriction, which I think you've gone a long way toward explaining. But as far as the diagnostic category, most of them seem to fall into the borderline personality organization of Kernberg. And I know you mentioned high functioning and a whole variety of different types. But here's my question. Do you find any correlation between, since they have intense separation anxiety and severe borderline personality organization, do you find any correlation between that and propensity to panic attacks? And if not, is there any one diagnostic category that in your basic sense of panic attacks you find a very high propensity for panic attacks?
I've actually written a couple of articles on this. That I think the term borderline also covers a very heterogeneous group of patients, and that range from people who seem to have some variety of bipolar affective disorder to some variety of rather peculiar kind of personality difficulty. The thing I've been actually struck by is the difficulty a lot of people have in distinguishing separation anxiety from sensitivity to interpersonal rejection. It's not quite the same thing. That is, you have frequently in the context of a romantic situation that there's a breakup. And more often, I would say among females this occurs, that it's the devastating experience having had this romantic breakup. And is that because they are feeling rejected and they can't stand the notion of being rejected, or because they're feeling separated? Can you make that distinction? I think you actually can, because many of the people they call borderline, you'll find that in all sorts of aspects of their life, in their jobs, that if they're criticized or put down, their reactions out of all proportion. So not simply the separation aspect of the thing, it's really what they experience as a terrible put down. And in our studies on depression, we were able to, at least fairly convincingly, I think, to show that all the peculiar things, the MEO inhibitors, as a class of drugs, are useful for rejection sensitivity. We did this study on atypical depression and layered out within the atypical depressive group the patients who also met the DSM-3R criteria for borderline: intensely unstable, involved often in things like self-cutting, internal hostility at times. And so how did they do in their own inhibitors? One usually expects that personality difficulties would do worse on any sort of treatment, including pharmacology. In fact, strangely enough, they did the best. That that particular group of atypical depressives had, at least temporarily, stunning responses to their own inhibitors. And the thing that they would say themselves is that rejections that previously they would experience as crushing and angering, they were able to just shrug it off. Okay, that's their opinion. So I hope that helps some.
Yeah, I like everything you did and said. I just am curious. I'm interested in children and adolescents who are in psychoanalysis or psychodynamic therapy. And there's much in the literature and much that I understand that some of these patients, adolescents and children, have panic attacks in the session or in the course of their therapy. And it's the tradition, more or less, that analysts, and certainly child analysts, well, that's changing a bit, don't give medication of any kind, because that's just the basic principle of psychoanalysis, not to medicate. And I just wonder if you have any data or have done any research with adolescents or children, or even adults, who have been in treatment and who experience panic attacks, shortness of breath, palpitations in the course of a session, and who don't have any medication. Have you any data or have you studied any of these people to see whether they get over their panic attacks by the so-called talking cure? Or, okay, I think you understand my question.
Unfortunately, the short answer is no, we really don't have any data. We just don't have any data. And the anecdotes we have, but anything in the way of systematic data, we don't have it. That really can't be helpful.
Klein, actually, we're greatly in your debt for having given us probably the most powerful explanation for what panic disorders are about. Certainly used it very effectively in treatment situations. There are three things I want to ask you about. The mechanism for the self-termination of the panic attack. I mean, what happens at the 4th or 5th minute to bring this to a conclusion? Secondly, even though the panic attack may be associated with the suffocation response, ultimately one would think that there would be possibly some provocation or stimulation of the HPA axis, simply if you feel like you're suffocating at some point along. So I'm interested in what inhibits the HPA from coming in, even though your explanation as to it being, inefficient for the HPA to be mobilized, since obviously if the HPA is mobilized, you're going to be more intensive in your oxygen utilization. And finally, since you made a linkage with people who have separation anxiety, is it possible that early in life, trauma of a separation nature may have an adverse effect, even on those who are not genetically predisposed, to somehow altering the opioid system? So essentially, there's a causal factor there.
That is an interesting question. According to my understanding, when we give people carbon dioxide, or we give them lactate, and they have a panic attack, we terminate it. We do not continue with carbon dioxide or lactate. In the early days, the studies were done by Ferris Pitts, who was the first person to give intravenous lactate in these situations. They didn't do that. They continued the lactate throughout the entire 20 minutes, regardless whether they panicked or not. And they had much more wipeout effects on those people. Now, let's say we're thinking in terms of the person who's having a panic attack out of the atmosphere. The question is there a safety signal that's coming across that's saying you're not suffocating? But as I think I've shown you, during the panic attack, you are hyperventilating. It's not what causes the panic, it's part of the panic. The hyperventilation is blowing your carbon dioxide off, so that at a very low level. That, I think, is a safety signal that says to the brain, you can't be suffocating your carbon dioxide down to 30. And that, I think that is, now, how could we experimentally test that? Well, we haven't done it. But the way you would experimentally test it is you would put somebody in carbon dioxide, have them panic, and keep them in carbon dioxide. So that the hyperventilation would not lower their blood carbon dioxide. At that point, if I'm correct, their panic should be extended. That's open to experimental test. Another point was that is there something that inhibits the HPA axis? I don't know what that could be. However, I will tell you that there's an extensive neuroscience literature coming out of the past 2 years on inhibitory circuits to the CRH, to the hormone released by the hypothalamus that affects the pituitary, that affects the ATA, so that we know there are inhibitory circuits in there, and you can turn them off. Whether they are active in panic disorder, I don't know. But it's not like we don't know of any inhibitory circuits. They do exist. The third point was about separation trauma. The best studies have been like these long-term Zealand studies, and there are also a number of retrospective studies. In fact, we don't find a relationship with separation trauma. We all actually hope that we would, but we don't find it. Separation anxiety and separation trauma do not seem to be tightly connected, at least at the level of separation trauma that we've observed. So that right now, the answer seems to be no, but that may be a limitation of our data.
As you can see, we're on the spectrum and a little bit more in the hypothetical, speculative end of it. But let me just go quickly through this. During the study, the people there were some unblinded, I didn't tell you this, but there are several, this is a composite of several studies, so we know that what some of them received, which is naloxone lactate. Those who received on one day naloxone lactate, whereas those who only received lactate, they will describe that they are completely exhausted. And a lot of these are Columbia students, they will never do anything until the next morning. They just crash. And some of them sleep for 5 hours and all that. There's something about the opiate repression that does that. It's not the lactate. That's true whether they had a full-blown panic attack or not. Second, what was the second point?
Inhibition of the HPA.
Yes, thank you. We've been talking about substance for a long time. What looks like HPA activation may be vagal withdrawal or the vagal breaks. It's very complicated, but I think it makes a lot of sense to assume that if you're suffocating, it will speed up your demise to activate your fight and flight axis. And then again, very speculative, but perhaps not so on an observational level. You have to go back a generation or two. There's something transgenerational here, just like in depression, as recently again shown by Myrna Weisman. There's something that is not just in the index case, but goes back to the parents' early upbringing, and it's basically what we would now call epigenetics. It's important to look at that.
My name is Damon Feldman. I'm a neurologist. And firstly, with regard to migraine, there have been a number of surveys done among neurologists at our national meetings. The incidence of migraine in neurologists is 40%. I belong to a group of 5 neurologists. 3 out of 5 neurologists have migraine.
Which would make for a very interesting hypothesis why neurologists are so averse to look into certain aspects of
Absolutely. I must tell you that I found this presentation fascinating. And this type of material is not available on other literature. This is new stuff for me. The comment I wanted to make, though, is that when neurologists hear about lactate, we think about mitochondrial disorders. That's the direction our brain goes. And we now have a whole collection of mitochondrial enzyme deficiencies in which people are subject to periodic elevations of lactate.
They have migraines.
Some do, yes, that's a part of it. But there's a natural model for people who have fluctuating lactate levels. And these are people that have labus hereditary optic atrophy, progressive external ophthalmoplegia, MELAS, a number of different disorders. The spectrum of mitochondrial disorders is very broad. But they're a natural way of looking at when these people have fluctuations in their lactate, those who are subject to panic attacks, when their lactate goes up, are they more likely to have panic attacks? Or the same thing, if we gave them naloxone, How would those who are prone to panic attacks, how would they make out since they have a predisposition to elevation of lactate? And on the other side, the treatment that is primarily used for mitochondrial disorders now, which is not a very effective treatment, is coenzyme Q10. And coenzyme Q10 is a respiratory enzyme. It's part of the respiratory chain. So it tries to make up for the absence of the mitochondrial enzymes. Now, coenzyme Q10 has just been used in migraine and seems to have some benefit. So would panic attack patients benefit from coenzyme Q10?
What was it trying? Anyway, I can't do it. But I'm going to say this about lactate. It's very complicated. I can drive up the lactate by holding to run very fast for 5 minutes. But running seems to be a treatment for panic rather than an exacerbator of panic. Now, so how do you put those two together? My guess is this, that I think our brain suffocation detector is complex. It's taking a full source of information. And that if you're running the lactate goes up, I think it says what do you expect when the running the lactate goes up. But we're giving people that are lying in bed an intravenous infusion and their lactate's going up. At that point, I think the suffocation detector says, hey, what's going on here?
Well, I'd just like to say that my separation anxiety is a little bit up because I know that some of you wanted to ask questions and you didn't get called on, but I think that we're all running out of acetylcholine and norepinephrine at this point. So also, but since most of you, including myself, have been psychoanalyzed, I know that you have the capacity to think about your feelings about not being called on. So that protects me. That sets us up for next month, thinking about feelings, and I want to thank our presenters for a fabulous